It's a pleasure that I'm going to be talking to you about the concept of choosing wisely. And as Professor Sidika said, this is a concept that has been going on across the world, that we're going to talk about choosing wisely Africa. As they said, Fidel Rubagumya. I'm a clinical oncologist at Rwanda Military Hospital and a senior lecturer at the University of Rwanda. So the background of choosing wisely, as Dr. Sidi said, it's really a concept that started in the United States with the American Board of Internal Medicine, but it spread across other disciplines in medicine, internal medicine, surgical disciplines, but also palliative care, and then oncology. And also oncology started from the US, as we are going to see. And the aim of this concept is really to advocate for a conversation between physician, patients, and to extent policymakers, to have a discussion about the use of different medical interventions and also different medical tests that we use in our practice. And the major concept that we are talking about is the value of cancer care. Now, this is choosing wisely globally in terms of oncology. We talk about the value in cancer care. And when we are talking about the value in cancer care and practices that are usually of low value, costly and harmful, that we can remove from our practice, that we are used to do in our practice, but we are also saying that these are practices that we should be removing from our practices. And here on this slide, I show you two examples. For example, is there a role of doing metastatic workup or imaging in patients with metastatic disease, for example, breast cancer? As if a patient has no symptoms, would you want to do imaging on this patient that is responding well to treatment? Would be willing to do imaging on this patient? Or is it really necessary to do aggressive treatment for patients who are at the end of their life? Or should we let these patients rest well with their families in their homes? So these are the practices that we are trying to advocate that they should not be practiced on the continent. And the equation of value in cancer care or value in healthcare in general has three components. One is the quality of the care that you're giving to the patient minus the adverse effects of the treatment that you're giving over the cost. So as any other mathematical equations, if the cost of care is very high, it will reduce the value of the care that you're giving your patient. And if the side effects of the treatment you're giving is also high, then the value of the care that you're giving is going to be reduced. So to balance, you have to make sure that whatever you're doing to the patient, it has high quality, low adverse features or toxicity, but also the cost of that intervention or test that you're doing is low. So is minimized so that you can increase the value of care that you're giving. So the choosing wisely concept is applied in different fields. There is research, there is screening, prevention, and early detection. It can also be applied in diagnosis and treatment, funding of healthcare, but also healthcare workforce planning. So all these are different areas where we can apply choosing wisely. So choosing wisely in oncology started in the US, as I said. So the American Society of Clinical Oncology published their first 5 recommendations. And then ASH, which is the American Society of Hematology, also published their list. And then it spread all over the continent of America in Canada, and then moved even to India. And it's the Indian colleagues that really motivated us to also go for our own Choosing Wisely Africa. So they also published their different lists of 10 recommendations that they recommend that clinicians do de-implement. So in terms of thinking of choosing wisely in Africa, we know that the cancer burden in Africa is rapidly increasing. We have limited resources on our continent in terms of healthcare, but also we have limited workforce in our, especially in oncology. We are still limited in terms of the oncologists or physicians who are practicing oncology on the continent. So the question was whether choosing wisely is really relevant in our continent. Are we able to deliver the best care at the possible minimum cost on the continent? Can we avoid financial toxicity to our patients, the families, but also society at large? And can we be good stewards of the little resources that we have? And then we thought yes, we answered yes to all these questions, and that's how we started with Choosing Wisely Africa. And to select a practice to put on the recommendations, we based on different criteria. And one is that the practice to be de-implemented would have to be of evidence, of low evidence in terms of the literature that is available, should be highly frequently utilized on the continent, should be of cost was also one of the criterion that we used to put a recommendation on the list, but also to be clear in terms of the wording so that practitioners who are going to be, who we are asking to implement these practices really understand the concept. And of course had to be relevant to the context of the African settings, with also possibility of measuring these practices in the future to see whether they were implemented or they had impact in the practice and so on. And also targeting the kind of the practice that we are targeting were practices that have no benefit or have marginal benefit, or practices that have that patients do not really desire to do. For example, if you ask a patient to do a PET scan and the patient says, no, I don't feel I want to do it, then it's no of value to do that test if a patient or the family has really, after your education, your everything, they decide they don't want that practice. Also, other targets that we are looking at are the practices that have equivalent and cheaper alternatives. These are also the classes of intervention that we are targeting, asking the physician, asking the oncologist not to do in our daily practices. So we published our first 10 recommendations of Choosing Wisely Africa of practices that we think are of low value, harmful, and sometimes costly to our patients. So this publication was in 2020. And it was an exercise we did with colleagues from Africa from different disciplines. We had surgeons, we had radiation oncologists, we had medical oncologists, we had policymakers and patient advocates. And we held a lot of meetings to come up with the final 10 recommendations that we believe should not be practiced on the African continent in terms of oncology. And after the exercise, we had, as I said, we had 10 practices or 10 recommendations. One of those was a new recommendation, but 9 others were either revisions from other Choosing Wisely initiatives from Canada, US, India. And we had one item that related to palliative care, 8 practices concern treatment, and also one that relates to follow-up after treatment or surveillance of cancer patients. So I'm going to go through a little bit quick in all those recommendations, but I'm probably only 2 or 4, and then I will request you to really read our paper to understand more about the Choosing Wisely Africa recommendation. So, but this is to give you a glimpse of what we are saying. So number one that we put on our list is to ask fellow oncologists to not order a test to detect recurrent cancer in asymptomatic patient if there is not a realistic expectation that early detection of the cancer can improve survival or quality of care. So I'll give you an example, but we give this in the detail in the paper. For those who treat breast cancer, you know sometimes that during follow-up, sometimes we do request CA 15.3. This is a tumor marker that honestly in patient who is asymptomatic, who doesn't have a metastatic disease, it will tell you that this is normal or this is increased, but it will not tell you anything about whether there is a new disease, a recurrence, or anything. And it's not going to improve any quality of life to this patient or survival in this patient. But rather, it might prompt you to actually do more testing. Like, okay, now it's elevated, let me do a CT scan. And after doing a CT scan, you find it's normal. Then you tell this patient, come back in a month. So you find like you're going into a series of tests that are not necessary. But I'm going actually to put this patient into more anxiety and other issues that you could have avoided by not doing that test. So this is what we are asking physicians not to do in asymptomatic patient. Then number two, do not decide treatment of potentially curable cancers without input from a multidisciplinary oncology team. We know that sometimes in our practices, you sit in a room alone and you decide for a patient without any input from surgeons, radiologists, or any other member of oncology team. And this is not a better practice for a patient. As we have seen, there's a literature evidence about that multidisciplinary team actually improves the care of patients. So we're asking that do not start any treatment for creative intent for a patient with cancer without consulting other team members. And then we have others. For example, do not initiate cancer treatment without defining the extent of cancer, which is staging. Sometimes in our practice, we start treatment without staging. But we know that the management of early stage and metastatic stage is different. So if you treat a patient with metastatic disease as if you're treating a curative intent, then you're causing a lot of toxicity to this patient without benefit, really, in terms of overall survival. So these are the recommendations that we are putting there. So there are different other recommendations that I'm not going to go into detail because of time, but I request you to really go through that and see. For the surgeons, we ask that you do not perform surgery to remove a breast lump without histological confirmation of malignancy unless a needle biopsy cannot be performed. So we know that there are some, in our practice, at least in my practice, I see sometimes patients coming to me with already mastectomy, but it's actually not a real mastectomy. It's a simple mastectomy to remove a lump that after pathology reading, you find it's a benign tumor. So we are requesting surgeons not to really do amputation of the breast, because that is really amputation. It's not a clinical mastectomy without having a biopsy. So do a biopsy. If this tumor is malignant, then do a proper surgical resection of breast cancer. But if it's a benign tumor, then you don't need to do the surgery. So that's what we are requesting with this recommendation. So we have published this list of 10 practices, but of course they are not the only one. Hopefully, as I'm going to show you in the future, we have other plans. But going forward, only publishing a list, we know that can only do little. We cannot think that by publishing, we are going to actually get impact of just publishing the list. So the plan is to increase awareness of the list, implement it in our clinics across Sub-Saharan Africa, measure the success of these recommendations, and also keep updating the recommendation with new practices to be removed or new practices to be added on our list. So we did that. This year we published our paper regarding the awareness. So we surveyed several African oncologists, asking them whether they agree with the recommendation. Because when we did the first Choosing Wisely list, we only involved about 10 oncologists from different parts of Africa. But this one was to really validate the Choosing Wisely recommendation. So we did this survey and included 15 countries from across Sub-Saharan Africa with 69 oncologists practicing exclusively in public health or public hospitals, but there were others also practicing in private practice. And generally, there was really a good agreement. So all the physicians or the oncologists we asked, they were agreeing with the recommendation with a range of 84 to 98%. However, we also picked up several barriers that these oncologists mentioned that would be difficult to implement Choosing Wisely in their practice. And with that, we also published another article about these barriers with also solutions that we think are there to actually make sure that we implement Choosing Wisely in our practice. But what we found was that the challenges that are there are of fourfold. One is that they are patient-related. For example, there are patients who think if you don't do a lot of tests, then you're doing nothing as a doctor. So we need to work on that front. And then healthcare provider-related. There are also physicians who believe that if you ask a lot of tests, then you're going to go to get more information, even when they are not really necessary. And then health system-related. There are hospitals that generate income by doing a lot of tests. So if you're going to minimize their income by reducing the tests that you're doing, they are not going to be welcoming that. And also society, kind of the same with the patient. There is a society that believes if you come and tell a patient that I don't think you need to do any test, they will say, oh, this doctor doesn't know what they're doing. So these are the areas where we think there are barriers, but we also provide solution in this article, and I encourage you to read the article also. In terms of raising awareness, Choosing Wisely Africa, in collaboration with eCancer, we are also having a module or e-learning that we are starting soon, and encourage people to actually join soon. So the module is going to be, showing you all the guidelines about Choosing Wisely, but also, giving lessons learned from other parts of the world. So please log into the Choosing Wisely website to look at the Choosing Wisely Oncology Africa e-learning module. And then from the awareness campaign, we are also now moving forward to in terms of trying to see how now Choosing Wisely Africa is implemented in our daily practices. So in terms of measuring the impact of Choosing Wisely Africa, we have already started implementing this. We are now doing a study in different African countries to see how the Choosing Wisely now is implemented in our clinic. So we are looking at, for example, using the practices that we published in the Choosing Wisely Africa recommendation, and then going in our clinics and seeing whether people are actually following the recommendation. So we are doing studies in these 5 countries, so Rwanda, Senegal, Kenya, Ghana, and Tanzania, to look at the impact of Choosing Wisely Africa. As I close my talk, I hope that when we go back in our practices, we are going to be asking these 3 main questions. One is, when you're ordering a test, you should be asking yourself whether the request that you're doing, actually you should be requesting it, whether the test is going to inform any decision that you're going to be making. Also, when you're deciding about the treatment, you have to always ask yourself, should I really be prescribing this treatment or not? Is it evidence-based? Is it cheaper than any other alternative that is available there? Have I considered the patient in this case? Are the patient needs met with this decision that I'm making? Have I also considered the financial status of this patient and the family at large, but also the financial status of the institution or the health system at large. And with that, I would like to thank you so much.